Hi Farmies, today I'd like to talk to you about ACEs and ARBs. So we already did one of the ACEs, we did lisinopril already, but we'll also do enalapril today. It'll be kind of a refresher for ACE inhibitors, but then we'll also talk about ARBs, so our angiotensin II receptor blockers. So ways to remember these is ARBs usually end in sartan, so either losartan or valsartan. ACEs usually end in pril, enalapril, lisinopril. And so let's talk a little bit about these. So our two drugs are enalapril and valsartan. And so this is the renin-angiotensin aldosterone system, RAS. So we have the liver producing angiotensinogen. We have your kidneys coming in with renin. And this whole system works together. Angiotensin 1 becomes angiotensin 2, which binds to the angiotensin receptor. And then we get an increase in aldosterone, which is like the body's salt. We get an increase in H2O, resorption by the kidneys. So the kidneys hang on to fluid, and we also get vasoconstriction. And your body is doing all of these things because what we're trying to do is increase your blood pressure. This all started with your body sensing a decrease in blood pressure, or what it interprets as a decrease in blood pressure. So it might just be a lack of cardiac output, which your body can misinterpret, which is the problem with heart failure. Because your body is misinterpreting those signals. So we don't want this increase in blood pressure. We want to give a medication to decrease blood pressure, to treat hypertension, and we want to decrease the amount of fluid, so we want to treat heart failure. So that's what these two are going to do. And the way we do that is we give an ACE right here to block the conversion of angiotensin 1 to angiotensin 2. If we have some of the side effects of ACE inhibitors, which are because what it also does is they block bradykinin, bradykinin's inactivation or breakdown. So if we get those side effects, cough is one. The other one, it's a very big one, is angioedema. So I was looking at this, and in some research I found that African Americans are 3 times more likely to experience angioedema as a side effect of ACE inhibitors. So that's one thing to be concerned about. This is not going to be therapeutic for your African American patients, and you'll find the physician probably chooses something else, like an ARB. So if your patient can't take an ACE, they might take an ARB. And the ARB works by not allowing angiotensin 2 to bind to its receptor. So we're going to block those receptors. And when we block all of this, when we block any part of this RAS system, we're going to get, we're going to block the vasoconstriction, so we're going to get the opposite, vasodilation. We're going to block aldosterone, we're going to block the water retention. So instead of this increase in BP, we're going to get hypertension. We're going to treat hypertension with a decrease in BP. We're going to treat heart failure by having a decrease in workload because we have less fluid in the body. Okay, so there you have it, ACEs and ARBs. Great to, oh, I have one more thing I want to tell you about these. What also happens is your patients, if we're giving an ACE or an ARB, they hang on to potassium. So what you also get, in addition to we're treating hypertension, we're treating heart failure, but we are also having an increase in potassium. So we need to be careful and talk to our patients about restricting the foods that they take in that contain potassium. So look at your nutrition book and see what contains potassium. And these patients are not going to need as much of that because their body is going to be retaining it. All right, so aces and ARBs. Have a great day.